Good morning. As mentioned, my name's Jack Blake and I'm fourth year medical student studying at Keele University, and feel very privileged as a medical student to be able to address you all today and to talk about a project I completed in my third year of study. Just a bit of background. NICE estimates that there's 200,000 people a year admitted with head injury, and of these, a fifth will have evidence of skull fracture or traumatic brain injury. Traumatic brain injuries can lead to an alteration in brain function, seeing a spectrum of decreased consciousness, retrograde amnesia, neurological deficits, and changed mental status. Some specific syndromes to describe the symptoms following a traumatic brain injury are diagnoses such as post-concussion syndrome, which describes a set of physical, cognitive and emotional symptoms. It's estimated that most of these patients with post-concussion syndrome will make a full recovery after a year. I've conducted a literature review to explore these outcomes and to see these patients long-term and to determine to what extent a full recovery is achieved, with a focus on depression, psychosis and cortical dementia in this group. A bit about my methodology. I used the EBSCO host core medical databases, and I searched the literature for articles published within the last 15 years and matching searches related to traumatic brain injury, depression, psychosis and dementia. On review of the articles, my inclusion criteria was patients who sustained traumatic brain injury but with reporting on depression, psychosis or dementia for at least 1 year, and then any papers looking at predictors of outcome following traumatic brain injury relating to recovery of memory or non-head related trauma was excluded. This identified 16 papers, and 5 of which related to depression, with 4 concluding an increase in the risk of depression and the other suggesting that persistent post-concussion syndrome mediates the development of depression following a traumatic brain injury. And for psychosis, there were 5 studies related to psychosis, with 1 suggesting no increase in the risk, 3 suggesting an increase in the risk, though 2 only where genetic predisposing factors were present. There was also an interesting case report from 2018 that suggests a new avenue for research with cannabis use and psychosis. Both cases were of young boys with previous traumatic brain injury and persistent cannabis use with the onset of psychosis at 18. Then the last area for dementia, there were 7 of the 8 studies agreed that traumatic brain injury increased the risk of developing dementia. 4 of these studies focused specifically on Alzheimer's disease as a diagnosis or the pathologies associated with it, like cortical thinning around the hippocampal regions or other beta amyloid blood tests. The other studies were more generalised about the dementia, and they grouped Alzheimer's disease, vascular dementia and unspecified dementias together. What are the potential implications of this review? There's poor evidence for the link between psychosis and traumatic brain injury. More research is required into the link between psychosis and traumatic brain injury and how this interplays with other intrinsic and extrinsic factors in bringing on a psychotic episode. This could impact acute mental health settings, and clinicians may be prompted into asking specifically for history of head trauma. Families and clinicians may not be forthcoming with this information if it's not deemed clinically relevant. NICE guidance at the moment doesn't have anything on follow-up for head injury in terms of managing the psychiatric complications. This review suggests there's strong evidence for depression as a long-term complication following traumatic brain injury. It seems important to at least warn patients of their increased susceptibility to depression and to educate them of this prodrome. And then finally, the strong evidence base for traumatic brain injury increasing the risk of dementia may pave the way to more medical legal claims. The findings of this review would suggest a strong case for medical legal action were the patient to have diagnoses such as Alzheimer's disease. However, were the patient to have another form of dementia like Lewy body disease, their case may not be as strong for compensation. So I think more importantly, this literature review highlights the importance of interdisciplinary cohesion, such as that shown in fields like neuropsychiatry. There are patients with clear psychiatric and neurological needs that can fall into placement limbo where there are not established services. Establishment of more neuropsychiatric services or ways to bridge neurology and psychiatry in areas where this is not yet possible may help address shortfalls in these patients' care.